even after to share the link. So welcome again. At this time, we're going to be having our opening prayer that will be done by Sister Diane.
Shall we pray? Oh, Father in heaven, we come before you once more today to give you praise and thanks for your blessed and holy Sabbath day. As we come to this evening session, I ask, dear God, that you would be with what will be presented, be with the presenter. As we have learned so much this morning, and now we are here to ask our questions. And I ask that you would be here with us in the form of the Holy Spirit. Open our minds, open our hearts, and as we gain the knowledge, help us to follow what is being said to us. We thank you again for this privilege where we can learn a little more of our bodies so that we can be more healthy, because you wish that we be healthy. So thank you again, and we ask that you would bless the presenter this evening, I pray, in Jesus' name. Amen.
Amen.
Amen. Thank you for that. And at this time, we're going to hear our theme song. Thank you so much. So although I introduce the speaker this morning, I will still, again, for those who haven't heard, tell you a little bit about Dr. Knight. So, Dr. Knight is a chair of Insulin Family Diabetes Institute and division and director of the Division of Endocrinology at Hackensack University Medical Center, and that's located in New Jersey. She's a graduate of Harvard Medical School. She completed her residency at some top hospitals in New York, Presbyterian and Columbia. She then pursued fellowship in endocrinology, diabetes, and metabolism at Albert Einstein College of Medicine, Montefiore Medical Center. So she comes very qualified and skilled in the field. Dr. Knight remained at Montefiore Einstein for 15 years, rising to the rank of Associate Professor of Medicine. She has had significant experience as a clinician, an educator, and a research investigator. At Hackensack University Medical Center, Dr. Knight manages a busy medical practice where she specializes in patients that have diabetes, along with other endocrine disorders. And over the years, she's actively engaged in educating the community on many health-related issues. And if you were at the presentation this morning, you see how great she is at bringing across points to us. And so at this time, if you are brave enough, you can unmute your mic to ask your question, or you can utilize the chat room. Jean, I will need your help to man the chat room in case a question goes there.
I have a question.
Yes,
Can I talk? Okay, I have a question. I'm diabetic. Maybe 6 years ago, I was diagnosed. So I'd like to know if I can reverse my diabetes 100%.
That's a great question, and one that is asked very often. Yes, you can reverse diabetes. Usually what it takes is a number of factors. One is really strict adherence to the diet. The diet that I find that helps the most in that is a plant-based diet. So with significant restriction in carbohydrates. So not necessarily a keto diet, because while you restrict carbs, then you're eating a lot of sort of protein and sometimes even a lot of fat. But persons who are able to follow a very strict plant-based diet, it takes time to perfect that. So you have to plan. I always recommend working with a nutritionist. On such a diet, one would actually lose weight. So weight loss is part of that. Exercising is part of that. Really minimizing any unnecessary starch. And so you can actually see with that type of plan, significant reduction in glucose and sometimes complete normalization. But we always have to remember that diabetes is progressive. So even with the best meal plan, exercise, and all of that, as we get older, as we age, the pancreas loses function. And so there is always that possibility. However, if you are able to normalize your glucose, you can actually improve the pancreatic function as well, because the pancreas will work better when the glucose is normal. A high glucose actually ends up being toxic to how it functions. So yes, you can reverse diabetes, and you can do that sometimes for months, if not years. And I've certainly had a few patients who have been able to do that. It's usually good to start on that pathway at the initial time of diagnosis and really to continue with some support. But it requires tremendous discipline, I would say, but it's not impossible at all. You start simple. You have to plan your meals, because as you can imagine, if to follow that, you will be doing most of your meals. It's very difficult to eat out and maintain the same level of discipline and the type of content and so on. And but it can be done.
Okay, thank you.
Thank you. Someone had a question about, I think, grandmother is diabetic. Okay. Okay, yes. So to some degree, yes, the question is, if your grandparents have diabetes, are you predisposed? And the answer is yes. So we sort of look at the whole sort of lineage. Those are still very close family members. A lot of the patients I see, their parents maybe have not developed diabetes yet, but the grandparents do. So certainly with that history in mind, you would want to be very careful about just how you eat, minimize weight gain. You want to exercise. So you pretty much want to practice as much as possible a very healthy sort of path. You want to be screened. You certainly want to make sure that your doctor is checking your A1C and that they tell you the result. Many people go to the doctor doesn't call you back, and you assume that the test is normal. Remember, we have many, many patients. The time I sit down to call someone is the same time I get an emergency call, and I never get to call the patient. So be very proactive. Make sure you call your doctor. You get the result for every test. If your doctor's office has a portal where you can see the labs for yourself, you don't need to wait on a doctor anymore. You should have access to that portal. It is your information, and you should be able to sign on. If you are with a hospital system, many of them now have changed their policies so that as soon as the labs come in, they're released to you and to the doctor. So always make sure that you're not missing out on your screening test. And then the other part of the question is, why would someone try so hard to manage their diabetes, was on pills, but now they have to be on insulin? That is a really good point. The practice of managing diabetes can seem like a defeating practice because the patient works hard, they take medications, they maintain weight, and for a long time, the glucose is normal. And then, at some point, we see that there's a change. And to the extent that insulin might be necessary, but that speaks to the progression of the disease. You can prevent the time when that transition happens. I have many patients who never transition to insulin, but there are many who will. diabetes is not a simple disease. There are so many things that might affect how you use insulin to control glucose. So for example, you are managing diabetes and you're doing a good job. Maybe you're developing another illness. You have no idea that that illness is happening because there's nothing that you can check. And the only thing that gives us a clue is that your glucose is going up. That happens with people with heart disease. Sometimes there is an impending blockage of the blood vessel or something. The patient has no symptoms, but we see that the glucose is going up. And so you ask yourself, what is going on? And so that's why it's so important to not depend on just a lab test that's done in the doctor's office, but to check glucose. At a minimum, you should check once a day. If you're just on tablets, that's probably, you can check in the morning. The morning glucose is really helpful because it tells us how well you handle glucose when you're actually not eating. And then you would check again later in the day, either at dinner or bedtime. If you are on insulin, you need to be checking much more frequently. So usually it's in the morning and then before meals and at bedtime. Of course, it's difficult to do 4 times a day. So I do give my patients holidays. Once I can determine that they're consistent, I would say, okay, why don't you take a break this weekend? Allow your fingers to recover and then we can reassess. That's also why I use monitors a lot on my patients so that they're no longer poking their fingers. So the issue with diabetes is that there is always a possibility for progression, either because it's the natural history of the disease, there might be some other illness going on, you might be developing a complication of diabetes, and the result of that is a high glucose. And so monitoring is what helps you. So I know that when someone has diabetes and they see that those numbers are going up, they always feel so defeated and so depressed. That's a normal response, I would say, but try to work with your doctor to understand what the numbers are telling you. The numbers are always trying to tell you something. And if you study the pattern, if you understand, sometimes we can actually figure out what else is going on.
Noah has a question.
My question is, what happens if you eat too much food?
Food or sugar?
Both.
Okay.
Okay, so if you eat a lot of sugar, Nora, especially at your age, I think that you have a really good and strong pancreas, okay, that can make a lot of insulin. So if you eat a lot of sugar, you're gonna get a burst of insulin and you're gonna lower that glucose very nicely, okay? And that's exactly what we want to happen. But for some people, they're not so lucky. And so they don't make enough insulin, and so the sugar stays high.
Doctor, I have a question
Yes.
that may connect to Noah's question. A lot of youngsters are now, I have another question, but really, I thought it's a good point at which you introduce the question as to what is happening, why so many children today are getting diabetes at such an early age.
Yes, that's a great question, Pastor. The main issue we notice is the weight gain. Too many kids are gaining a lot of weight very early in life. So it's always very shocking when I go to a pediatric diabetes practice and the kids are 7 and 9 years old and they have type 2 diabetes. They have adult onset diabetes as children. Our kids are not getting out enough. They're not playing enough. And that was before the pandemic. Too many schools do not have structured exercise programs. Everyone is gaming now, so they're sitting in front of a screen. That's a major issue. I think a lot of our kids are eating fast foods and processed foods. As you know, a lot of things that they're eating are really not nutritious. A lot of bagged snacks, chips, and things like that. Those are sort of almost like artificial food. And so I think that they gain a massive amount of weight, but weight and fat buildup causes resistance to the insulin that someone makes naturally. And so that, I think, is one of the main factors for our children developing diabetes at such an early age. The problem with that is that a child does not have the understanding of how to manage that disease or the capabilities. And unfortunately, because the complications begin when the disease takes hold, we are seeing now so many young adults in their 30s and 20s with heart disease, kidney failure. And that's because a lot of them started out with diabetes at a very young age.
Mm. Thank you for that. Can I connect them? I heard you using the whole question of the pancreas and the sugar, insulin. And I've had quite a few colleagues who have died with pancreatic cancer. Is there any interrelationship between pancreatic cancer and what you are talking about in terms of the production of insulin and diabetes?
Absolutely. So it's really a vicious cycle. Diabetes is a risk for pancreatic cancer. The onset of diabetes could be the first symptom of pancreatic cancer. So we've had a few patients who just developed a very aggressive type of diabetes, sudden onset, and we imaged them for whatever reason, maybe with abdominal pain, and we found cancer. We've had patients who were extremely well controlled and then had a very rapid deterioration in glycemic control, and we realized that they had pancreatic cancer. So what happens is the cancer infiltrates, it invades the pancreas, it destroys any type of cell, but certainly many of them destroy the beta cells that make insulin. And so someone with pancreatic cancer, just by having the cancer, may no longer be able to make the insulin that they need. Also, the treatment for the disease, which usually involves surgery, leads to resection of a significant amount of the pancreas. And so these patients, if they did not have diabetes before, many of them will develop diabetes after. So I think in time, we're going to learn more and more about this association between pancreatic cancer and diabetes. But as it is now, we are very concerned that as we see more cases of diabetes, we're also going to see more cases of pancreatic cancer.
Thank you.
I have one more question.
Yes.
For someone with diabetes, are they more prone to have early Alzheimer's disease?
There is an association with Alzheimer's and high glucose, so maybe it's the resistance that happens. I can tell you that if someone has very high glucose, I have a few patients where the glucose is in the high 300s all the time. They're of a certain age, over 70. If this happens week after week, month after month, their cognition, their memory goes down. I've certainly had situations where I had, let's say, a couple, and I'm treating one of them who has diabetes, and the other spouse says to me, you know, I think this person is developing dementia. And then we treat the diabetes, normalize the levels, and they said, oh, this person is thinking so much better. So yes, there is certainly an association with just high glucose by itself giving you, you know, decreased cognition. And there's also this association with Alzheimer's.
Thank you.
Hello, good evening. How is you doing? I have a question. And my question is, what is the benefit of adding on the new medication Jardines for a patient? Yes, for a patient who's currently taking metformin 500 milligrams extended release twice a day, who had surgery for RCA and LAD blockage and had to get stent replacement, stent placement. What is the benefit of adding on that other medication?
That's a great question. So Charlene, Jardines was approved several years ago, and it was approved for diabetes treatment. And the way it works is that it increases the amount of glucose that comes through the kidneys. So they excrete a lot more. But the studies have shown that this medication is important for persons with heart disease. It reduces the incidence of heart failure. It reduces the hospitalization for heart failure. And we also know that it has some benefit for the kidneys. So the way that the studies are driving the management is that these medications are now considered medications for heart disease. And so that's why they are added to metformin. However, with someone who has known blockage in the heart, you would have to talk to the doctors, because while Jardines could have a role, you might want to question whether a once-a-week injection like Ozempic, that might also have a role, because that is another class of medication that has been shown to have benefit for the heart. So the way we think about diabetes management now is it's all about improving heart health. That's what it's about. So metformin has some benefit for the heart as well, but it doesn't compare to medications like Jardines or the sister drug Farxiga. Those are going to be our go-to medications. Now, these medications are not trivial drugs to take. One, they cause increased urination for many people.
Yes.
Those people who have heart failure, they actually act like diuretics. That can actually be beneficial. But in that setting, it also drops the blood pressure. So the doctors have to be very careful about how they titrate and adjust the other medications to make sure that it's just right. So patients can have dizziness and so on. There's a risk for urinary tract infections, yeast
And also
infections,
DKA,
and
yes.
DKA, exactly, the atypical ketoacidosis. And because they're given to patients with type 2, they're not trained to know when they're developing DKA. So there are not necessarily tight guidelines about that, but for Jardines, for example, if someone is having surgery, you would stop it at least 3 days before and also after. I actually would have my patients check ketone levels before, so that they understand what their baseline ketones are. So if they get weak, if they have nausea, they know to check that so that we can know how to adjust it. Some people complain about, because you're passing so much glucose through the urine, it's a very uncomfortable feeling to actually go to the bathroom. So I have many patients who cannot tolerate them. Cost is prohibitive. These medications are $400 plus per month. So if you do not have good insurance, it's extremely difficult. But even with the Medicaid plans, we have been able to get them approved if someone has heart failure, and we can prove that there's going to be a benefit. And so I see this wide, we will have expanded use, but we also need to have expanded education. Many of our internists do not understand how to use these drugs, and we are seeing a lot of complications. They keep me busy managing these DKA patients. And these patients, they are different because the glucose is normal, but they are extremely acidotic. And an emergency room doctor may not even know that that's what's happening.
May not have realized it, yes.
Yes, and so they when we say to them, the treatment is insulin, they said, no, it's not. The glucose is 125. So yeah, it's a challenge. So even for our hospital, we're about to launch a major sort of educational effort to really try to get everyone on board.
So from your practice and what you've utilized in regards to these meds, which one would you recommend? Which one do you feel more comfortable?
Okay, I would say Jardines is the one that I feel comfortable with, mainly because it's just duration of use. It was the first one that was studied and proven to have this cardiac benefit. So then I started using it. It's a reasonably good drug in terms of glucose lowering. But I would say though that for the cost, these medications are just modest in terms of how they lower glucose. Metformin is much better. Glipizide is much better if all you're doing is lowering glucose. So when I present them to the patient, I really have to do my homework and make sure that all the indications are there to justify the use of this medication, because for the most part, I'm using it now for heart health, not so much for glucose lowering.
Okay, so heart health.
Yeah, because that is what the studies, and whether you're looking at Jardines or Farxiga, so those are the top two, because those are the two that have really, I mean, the studies are coming out like every few weeks now, but
Okay.
they are lockstep and parallel. Invokana is another one that had benefits for the kidneys, certainly, but then they saw some signal where they thought that maybe there was a risk of foot amputations, and that just gave
Okay,
me,
that's a major side
yeah,
effect right there.
that gave me reason to pause. So in my own patients, if there's any issue of a non-healing wound, a prior amputation, we are not going down the path of Invokana. Steglatro was the last one to be approved. The studies, in my view, are much weaker than Jardines or Farxiga. So if I'm going to choose, it's really going to be those two are going to be my top choices.
All right, and the side effects, we could have, you said UTIs.
UTIs, yeast infections,
Yeast, okay.
women especially, because, you know, we have a very short ureter.
Yes.
Yeah, they are prone to urinary tract infections. The other thing is they induce this increased excretion of glucose. If your glucose is 400 already, and you take these medications, you don't just have glucosuria, you have frank incontinence. So patients have had very, you know, uncomfortable situations with these medications. And in order to really get the buy-in from the patient, we have to educate them about what to expect and what to do. And we have to be careful. If I have a truck driver, this is not his medication, right? How is he going to go to the bathroom, let's say? So we have to really think about for whom this is the best choice. But I can tell you that my patients with heart failure, when I adjust the medication and I add one of these, if their heart was functioning at 40%, I've seen it go up to 60%.
The EF moved to 60%?
Exactly. So these
Wow.
medications have really,
Okay.
and it's not just for reduced heart failure anymore, because the Jardines study came out, and even when you have preserved function, it seems to work. So it's going to be you know, the next few months are going to be really exciting when all the studies are, you know, put together, and, you know, we'll see. So a lot of hospitals now are actually thinking about how do we add these drugs that have heart benefit to our formulary, and who should benefit. And we are looking significantly at the heart failure. We don't need pills in the hospital for diabetes. We have insulin, and that is the treatment of choice. But it's important that when we have heart failure patients, especially those with diabetes, that we have them on the best medication to get recovery. If not, you know, it's going to be a progressive decrease in heart function. And these patients, they do suffer when they're not being optimized.
I think in the chat, Jean, there are questions that you need to address to.
So this person is asking about insulin is so expensive. What resource can you give us to help these persons? Okay, I will actually send some information to Cami about that. So that is correct. Insulin is extremely expensive, $300 per month per insulin. That is prohibitive. So there are many companies now, Novo Nordisk and Lilly and so on, they all have programs that are for patients. It's an application. It requires the patient to fill out. You have to have a certain income level. Your doctor has to fill it out. I can tell you that it's not an overtly tedious process. I do it a lot for my patients. Most of these programs will give about a year of medication. And so that's how we've been helping our patients who do not have access. We, of course, get samples in the office, so we try to, you know, curate as much of those so that we can provide the help to the patients that need it. If we've run out of options, then, you know, the more expensive medications like Lantus and so on are things that we cannot really recommend. So then we will go to traditional insulins like NPH. Walmart has a brand called Rely On, and that's about $35 per vial. And a lot of my patients use that insulin because they can pay the $35 a month. That is certainly a lot cheaper than $300. So, you know, in this country, we tend to believe that a medication is expensive because there is no need for it. there is a huge need for insulin, and yet it remains one of the most expensive drugs. The issue with this is that when you have diabetes, you're not just buying insulin, because you can't take insulin just because you have the bottle or the pen. You now need the device to take that insulin. That's another cost. You have to check your glucose. You have to pay for test strips. So the cost adds up very quickly. So you've probably seen there are a lot of movement in terms of helping to make insulin cheaper. A lot of companies are trying to make cheaper insulins, but they're still at least $100 a month, and that's still too expensive.
I have a question.
Yes.
Is there any research study to cure diabetes instead of treatment? Because for the treatment, you will be always on the treatment. I understand plant-based diet help, but is there any study from the government or from the world that can cure diabetes?
Yes. So that's a really great question. Yes, we like to say that we are not in the business of supporting diabetes, but honestly, everything that we do now is essentially that, right? We're supporting diabetes because all we give you are medications to lower glucose. So how have people thought about this? Well, one option is a pancreatic transplant, and that can be true for someone with type 1 or type 2, where you sort of connect with a transplant team and you go through the whole process and you wait for that to be approved. There have been many studies looking at just taking the islets, so the actual pancreatic cells from a donor, and implanting them into someone who needs insulin, and see if you can have sort of cells that produce insulin. And yes, that can work, but just remember it's a foreign tissue. And so these patients would need immunosuppressant therapy. And so many times that does not work. We are looking at ways when diabetes is autoimmune, so it's your body attacking your pancreas, we're looking at ways to try to retrain those immune cells to change their memory to cells that will stop hurting your pancreas and allow the pancreas to regenerate. So there's studies looking at antibodies to block some of those negative effects. So there are many, there've always been many trials. It's just that we haven't had that home run yet. And part of it is just the complexity of the disease. Type 2 especially is extremely complicated. It's not just the pancreas and the liver, the brain is involved, the muscles are involved. Where is the resistance? There's a lot of things that we have to sort out, a lot of pathways. And so that is why it's not so easy to have a single solution, but I can tell you that there are many people who continue to work at this to try to find a cure.
Yes, there's a question in the chat.
Okay.
Doctors normally stop metformin while a patient is in the hospital, and why? And place them on a sliding scale insulin. Does this mean I have to stop taking metformin before I go to the hospital?
The concern we have about metformin is the risk for acidosis, meaning building up too much acid in the blood that can cause a lot of complications. So that's why, and those complications can get worse if you become dehydrated while in the hospital, or if you are doing imaging studies where you need contrast that can affect your kidneys, right? So a lot of what we're concerned about is, will you develop a problem in the hospital that might affect your kidneys and therefore cause metformin to be toxic to you? And that's why the medication is held, and the appropriate step in that case is to monitor glucose. And if your glucose is above 180 on multiple checks, then they can start a correction insulin, but they don't necessarily have to do it immediately. So the general recommendation is that if you're having surgery, if you're having any procedure, you would want to stop your metformin about 2 days before, and then resume once you're better, or 2 days after if it's something that's a very short procedure. So there are several medications that should be held. Metformin is one of them. Jardines that we spoke about earlier is also another, so that we do not have any complications.
Yes, I have a question about the insulin.
Yes.
I know insulin is expensive, but so many people are dying also from diabetes because they can afford to buy the insulin or the tablet to decrease their blood sugar. So I believe that if the government also can help funding Pfizer, because Pfizer make insulin also, and the same way they're giving free vaccine for COVID to stop people from dying, I believe that they can, how they can help to fund Pfizer to help decrease the cost of insulin to stop people from dying from diabetes.
Before the doctor starts to answer, if you have a secondary equipment in your home while you're asking questions, please. We're asking you since the program is being recorded and it is on YouTube.
Oh, that's Ben. I'm sorry, that's Ben.
Yes, yes. So please, can you let him take a little cheat time, sit beside you, and then allow the background noise to be heard. Thank you. Go ahead, Doctor.
Yes, so here's the issue. Yes, many people have died and are dying because of lack of insulin and because they are rationing insulin. So they can't use the dose that was prescribed. They use something less. And so the glucose is never controlled. And that's a major issue. I am not sure if the pharmaceutical companies are going to try to solve that, honestly, because they have become wealthy beyond any measure by overpricing insulin. So where the emphasis seems to be is to have them make sort of a more affordable insulin. And I think that there's been a lot of pressure coming from the government to really help them to do that. I don't really know that the government needs to fund Pfizer. I think Pfizer has a lot of funds that they could actually use to do this. But I think the government might have to just decide if they are going to have pharmacies or they're going to, maybe Medicare is one insurance that many of our citizens use. And yet Medicare for our citizens is the cost of insulin is prohibitive. So even with that, Medicare is a government funded insurance. They're not doing a very good job. So I think the government can do a whole lot better to ensure that insulin is much more affordable, if not just free, for those people on Medicare, those people on Medicaid, because they are the ones who are developing the complications and are suffering. And I think that the pharmaceutical companies, having acquired such wealth over the years, they too need to play their part.
Thank you.
I'll ask a question, Dr. Knight.
Hi.
This is a bit long-winded and deep, but I hope you'll appreciate it. So we are aware that the benefits of a plant-based diet, yet when we treat diseases, viruses, and other health issues, medications that consist of synthetics, plant and animal inputs are used in the treatment and nourishment of humans. Is it the case that our health depends on the proper balance of molecules, minerals from any source, exercise, and lifestyles? As an example, can humans travel to Mars and obtain nourishment on a pill that has all they need for nourishment and sustenance? and be healthy.
Yeah, I agree. Everything comes down to a balance, right? So we are thinking, sure, about plants. We are thinking about micronutrients. We are thinking about how the bacteria in our gut is also involved in how we are able to absorb and maintain nutrients. And I think as much as possible, part of what they might want to do is to try to think about all that's needed and maybe put it into a single pill. So the idea of taking a pill and then going to Mars and sort of getting a lot of your nutrients from that, it may not be it may not be far-fetched necessarily. I mean, I'm sure they're going to, you'll need other supplements, but there is a lot that you can sort of pack into a supplement. Yes, we use a lot of medications. I think part of it might be, I think our culture is one that we are somehow forced to see that the treatment is kind of in a pill. I am not always convinced that that's true. I think that there's a lot that you can do with diet that can actually help the person and that can really facilitate healing, and that you don't always resort to something that you have to take that's even synthetic. So when I have my patients, I try to spend a lot of time looking at eating habits and how that can be improved before going to something that's prescription, because I don't want them to think that that's the only answer to wellness. There's a lot more than that.
Thank you.
Thank you. This morning, someone had a question about when I spoke about the symptoms that are clues to diabetes: weight loss, increased urination, fatigue. Someone had asked, how many symptoms do you need? The answer is one. Usually you only need to have one symptom that really, that then shows us. But the unfortunate thing is, for most people, they have no symptoms initially. And so a lot of these conditions that we consider to be chronic and concerning, they are actually silent. And so that's why monitoring, that's why getting regular medical checkups is important. Do not be afraid of the doctor. Do not be afraid to talk about your past medical history. Your family history only informs us of what is possible, but that does not mean that you will develop that condition. Perhaps you might be doing a lot of things that is going to prevent you from having that same path. But being in tune and making sure that you really understand the numbers as they pertain to your health is very important.
Any more questions? If you have no more questions, you better ask them. This is one opportunity that you'll get that you will not get every week. Brothers and sisters, is there any other question in the chat, John?
No.
All right.
I have a question.
Mm-hmm.
And this was from during the presentation earlier today when we were talking about the different pills, the ACE inhibitors, with protecting the kidneys. And I just wanted to talk more because I still keep seeing a lot of African American and all these pills and with the association with angioedema. Just touch on it for me, please, because it seems like we are more prone to having the angioedema, but yet we are still always prescribing all of them, the lisinopril and those.
Yes, that is a standard treatment, really, because to protect the kidneys. We do prescribe to a lot of patients, but I think in deciding to do that for any patient, we need to educate them about the symptoms and signs. So one of those most frequent symptoms is the dry cough. Okay, the moment someone starts on these medications, and it has to do with how they tend to stimulate some of the inflammatory cells. So many patients develop a cough. They cough all day long, and that's true for the ACE inhibitors. The angioedema is something that they should know about. It can be very sudden in onset. It can be after the very first pill, or it can be after taking it for several years. So I think if persons really understand that, then they will hopefully be able to identify it quickly and know that you do not sit at home with that. You have to go to the emergency room. So far, those classes of medication still remain the best treatments for kidney protection. Do they always give the best blood pressure lowering in Blacks and African Americans? No. Calcium channel blockers might actually work better. Water pills may actually work better. So we have to essentially look at the benefits and the adverse events that could occur. It's good to know the person's history. Someone who has a history of significant allergic reactions, probably that would not be the treatment to consider. I think what actually works for many African Americans, honestly, in terms of protecting the kidneys, is controlling blood pressure. That is a single important thing, and normalizing glucose, because I have seen patients who are developing advanced kidney disease reverse that by normalizing their diabetes and really improving it, even though they had been on ACE inhibitors, because you could be on an ACE inhibitor and you still progress to very advanced disease. So education is key. Learning to identify the symptoms of angioedema, which is a very sudden onset of an allergic reaction with mouth swelling, throat closing up. That's a medical emergency that has to be dealt with immediately. I don't know if the ACE inhibitors will always be the treatment of choice. We have so many new things now, including the Jardines and other drugs that might have benefits for the kidneys and improving kidney function and improving the protein in the urine. And so it could be that within a few short years, some of these recommendations may actually change.
Sounds great. Sounds great. Because I've seen too many African Americans coming in the emergency room with angioedema, and the risk and what can happen to them. So
exactly,
I'm hoping.
It's concerning, but starting patients on those medications is also one of the metrics by which we are judged in terms of, are you following the guidelines, And so we have to really look at each person individually.
I'm not sure
Thank you.
whether Sister Camila is online at the moment. I know the hospital has called her away. So here's let me phrase a question for you as we are coming towards the close of the hour. If you should think of the most asked question in terms of your practice, and in terms of the kind of population that we have, we are trying to become one of the most educated, health literate agencies in Alexandria and the proximate areas from which the church members are. But we have online individuals, as I'm looking from Huntsville, Alabama. I saw one who happens to be my sister. And there are others from other places, New York. I think Shalane is from New York. And so forth. You have a lot of people following you from different places. So tell me, what would you consider, or tell us, what would you consider the most asked question that you have faced in this field in which you engage?
Yeah, I think really everyone wants to know, how long are they going to be on medications? That's really what everyone wants to know. It's difficult to conceive that it's going to be lifelong.
Yeah.
Everyone wants to believe it's going to be short-lived. Certainly with insulin is very challenging when you start that at first. And so a lot of it involves working with the patient to help them to understand what their disease is and why we are using it. So the problem we have in medicine is we do not explain to the patient why we are giving them the medication, how it works, how it will help them, what we're trying to do. And I think if we don't do that, then then there's no reason for them to follow through if they don't understand. And so that's really one of the biggest thing. Diabetes affects our communities disproportionately to any other communities. And we are usually, the diagnosis is very late, unfortunately, and the complications are very severe. And so, and usually the treatment is suboptimal. And it's not always because of lack of access. I think it's simply lack of education. And so the way to really counter that, honestly, will not necessarily be in the clinical setting. It will really be more in a community-based setting, because members of our community trust certain infrastructures more than others. So they would trust, let's say, the church. They would trust a faith-based organization. They would trust a community center more than they would trust a hospital. Yes. And so having, seminars like this, having workshops, when we're able to, having health fairs, those are all important things to do to engage the community. And I find that if you engage one or two members of a family, sometimes that's sufficient to really get them to change the entire behavior of how they might choose to shop, how they choose to eat, or their entire outlook. I have a lot of couples that I see and they come together, and I think that's actually great, so that they're in partnership in the management of the disease.
Yes, I'm about to close. I've had one question in the back of my mind, but I want to put it another way by saying that day to day, I have thought it as must be a very difficult thing to get up 3 times a week or 4 times a week to go to dialysis, both for the person involved and the caregiver who works with the person. It's, to me, a very painful process, very difficult process. How do you help those individuals to manage their emotional?
Yes, it's very difficult, and I can't imagine. I've certainly seen my patients go through that, and I think to spend 3 days a week, sometimes 5 a.m., to 10 a.m., and then they don't feel well afterwards. So they go home and they're very tired. They're always tired. It's just never a great day. And so it's important to check in with them, most importantly, and really see how they're coping, provide them with professional help as needed. I do not like to see my patients waste a lot of time on dialysis. So once they're being prepared for dialysis, I'm looking to see if they can get on a transplant list. I'm sort of navigating both at the same time. I work extremely hard to slow down or prevent the progression of kidney disease. So that is, in my practice, we are looking at the kidneys very, very closely. And we are thinking, and I refer to the nephrologist, and we're in discussion about how we prevent this march to dialysis. So I think for many people, if they had better control, better access, dialysis could be avoided. For many of the members of our community, no one discusses transplant with them. And that is unfortunate.
Wow.
I feel like that has to be a discussion that happens in tandem with the discussion about dialysis. So there is a lot that they can learn. I have seen that dialysis can improve lives. I have seen that. I've had patients who were very end stage. They got dialysis. They did very well. But I would not want that to become the norm for anyone.
Thank you. Sister Felicia, Sister Diane, either of you may want to say the vote of thanks for me. Which of you? Sister Felicia, she's a nurse, nursing educator in our congregation. Sister Diane is a retired nurse. So which of them is going to open your mic and just tell Doc thanks on behalf of Sister Camilla and on behalf of Dr. Blair?
Dr. Knight, it's with much pleasure that I want to say thank you so much, coming from the members of EWC SDA Church. We have learned so much. I know that I've asked a lot of questions in the chat, and it wasn't for me, but it's just to get your answer in order to answer my patients when I get back to work. And I am sure that my congregation has been blessed. And I do have friends online from Canada who have been blessed. And I thank you so much, because diabetes, hypertension, kidney failure has been a traumatic experience for their patients and their families, because we can't forget the family members, you see, but even for the patient more so. So I want to tell you so much thanks for coming and taking this time out to do this presentation for us.
It was certainly my pleasure, and I really appreciate the opportunity to do this. I think it's really important to get the word out, and for us to really be invested in educating our communities.
Dr. Blair, I will try to communicate to her in as much as she is able to hear and understand the kind of work that you have offered. Her confidence in you is a tremendous blessing. As we close out the day, I'd like to mention her in prayer, and I receive regular updates from her daughters. And each one I ask you to pray for her, that the Lord will continue to guide. The doctors are going through different motions at the moment. Again, whereas they had said she was just going to go home